Cholecystitis case study. The patient is a 35-year-old white female who presents with a sudden onset of pain in the right upper quadrant of her abdomen for approximately 8 hours. She has nausea and emesis and reports that the pain began earlier that morning after she had breakfast, and this became more severe over the past 8 hours and now is a constant severe pain in her right upper quadrant. Pain is worsened by taking deep breaths. Past medical history is remarkable for prior attacks, approximately 1 year ago, with epigastric and right upper quadrant, severe continuous pain that had occurred about 1/2 hour after she had eaten at a picnic. The pain at that time radiated to her scapula and improved within several hours of onset. She reports that she did not seek medical care at that time. The patient is currently on oral contraceptive pills. She has 2 children. The family history is positive for gallstones in her mother and older sister. Review of systems is positive for elevated temperature and chills over the last 2 hours, decreased appetite. She denies any other abdominal symptoms. Cholecystitis by Chinyere. A. Ugorji, MD. Definition. Cholecystitis is defined as inflammation of the gallbladder that occurs most commonly because of an obstruction of the cystic duct from cholecystitis. Cause. Risk factors. Increasing age. Female sex. Certain ethnic groups. Obesity or rapid weight loss. Drugs. Pregnancy. Bacterial proliferation may be a result of cholecystitis. Acute alkalous cholecystitis is caused by obstruction of the cystic duct, leading to distension of the gallbladder. Alkalous cholecystitis is related to conditions associated with biliary stosis, including debilitation, major surgery, severe trauma, sepsis, long-term, total parenteral nutrition. TPN, prolonged fasting cardiac event, sickle cell disease, salmonella infections. Diabetes mellitus, cytomegalovirus, cryptosporidiosis, or microsporidiosis infections in patients with AIDS. As the gallbladder becomes distended, blood flow and lymphatic drainage are compromised, leading to mucosal ischemia and necrosis. Retain concentrated bile, and extremely noxious substance. In the presence of prolonged fasting, the gallbladder never receives a cholecystokinin CCK stimulus to empty. Epidemiology. An estimated 10 to 20% of Americans have gallstones, and as many as 1/3 of these people develop acute cholecystitis. Symptoms. Upper abdominal pain. Nausea. Vomiting. Physical examination. Fever. Tachycardia. Tenderness in the rough or epigastric region, often with darting or rebound. Hypoactive bowel sounds. Murphy sign positive. It is performed by asking the patient to breathe out and then gently placing the hand below the costal margin on the right side at the mid-clavicular line, the approximate location of the gallbladder. The patient is then instructed to inspire, breathe in normally. During inspiration, the abdominal contents are pushed downward as the diaphragm moves down and lungs expand. If the patient stops breathing in as the gallbladder is tender and, in moving downward, comes in contact with the examiner's fingers and winces with a catch in breath, the test is considered positive. Murphy's sign has a high sensitivity and negative predictive value, however, the specificity is not high. Differential diagnosis. Abdominal aortic aneurysm. Acute mesenteric ischemia. appendicitis, biliary colic, biliary disease, cholangiocarcinoma, cholangitis, cholecystitis, cholecystitis, gallbladder cancer, gallbladder mucosal, gallbladder tumors, gastric ulcers, gastritis, acute, pyelonephritis, acute. Diagnosis. Laboratory test. Complete blood count. Leukocytosis with a left shift may be observed in cholecystitis. Liver function test. Alanine aminotransferase salt and aspartate. Aminotransferase AST levels are used to evaluate the presence of hepatitis and may be elevated in cholecystitis or with common bile duct obstruction. And elevated. Alkaline phosphatase level is observed in 25% of patients with cholecystitis. Bilirubin and alkaline phosphatase assays are used to evaluate evidence of common duct obstruction. Prothrombin/plasma thromboplastin time. Amylase and lipase assays are used to evaluate the presence of pancreatitis. Amylase may also be elevated mildly in cholecystitis. Urinalysis is used to rule out pyelonephritis and renal calculi. Pregnancy testing minus all females of childbearing age. Imaging recommendations. The 2010 American College of Radiology APRA. Appropriateness criteria. Sonography is the preferred initial imaging test for the diagnosis of acute cholecystitis, and scintigraphy is the preferred alternative. Computed tomography is a secondary imaging test that can identify extrabiliary disorders and complications of acute cholecystitis, such as gangrene, gas formation, and perforation. Computed tomography with intravenous contrast is useful in diagnosing acute cholecystitis in patients with non-specific abdominal pain. Magnetic resonance imaging, often with intravenous gadolinium-based contrast medium, is also useful in confirming a diagnosis of acute cholecystitis. Magnetic resonance imaging without contrast is useful to eliminate radiation exposure. In pregnant women for whom sonograms have not indicated a clear diagnosis, but contrast agents should not be used in patients on dialysis unless absolutely necessary. Computed tomography or MRI minus findings suggestive of cholecystitis include wall thickening 4 mm, cholecystic fluid, subserosal edema in the absence of ascites, intramural gas, and slug mucosa. Hepatobiliary scintigraphy minus 95% accurate in diagnosing acute cholecystitis. Hepatoimmunodiacetic acidosis and slow filling of the gallbladder minus the gallbladder. Common bile duct and small bowel fill within 30 to 45 minutes. Intravenous morphine. Administration can improve the accuracy of HBS by increasing resistance to flow for the sphincter of body, resulting in filling of the gallbladder if the cystic duct is patent. Endoscopic retrograde cholangiopancreatography minus may be useful for visualizing the anatomy in patients at high risk for gallstones if signs of common bile duct obstruction are present. Chest X-ray. 1. Assess for right lower lobe pneumonia. 2. Assess for pleural effusion. Treatment. Medications. Pain medication Demerol, continuous infusion, 15 to 35 mg/h for pain management. The classic teaching is that morphine is not the agent of choice, because of the possibility of increasing tone at the sphincter of body. Antiemetic minus Phenergan, if/im, 12.5 minus 25 mg Q4 minus 6 for PRN, PO/PR, 25 mg. Antibiotics ciprofloxacin, 500 mg PO Q12 for or 400 mg of Q12 for 7 to 14 days. Piperacillin/tazobactam-zosine, 3.375 gram of Q6H or 4.5 gram of Q8. Ampicillin/sulbactam-unicin, 3 grams of 6 or meropenem-merium, 1 gram of Q8. Intravenous cholecystokinin CCK has been shown by some to effectively prevent the formation of gallbladder sludge in patients receiving total parenteral nutrition TPN. Procedures. Placement of a sonographically guided, percutaneous, transhepatic cholecystostomy. Drainage tube coupled with the administration of antibiotics may provide definitive therapy. Endoscopic ultrasound-guided transmural cholecystostomy. Endoscopic gallbladder drainage. Alternatives to surgery. 1. Percutaneous cholecystostomy. 2. Extracorporeal shockwave lithotripsy SWL. 3. Oral dissolution therapy. Miscellaneous. Nothing by mouth because of expectant surgery. Minus a liquid or low-fat diet may be appropriate until the time of surgery. Intravenous normal saline stat immediately. Pulse oximetry stat immediately. Nasogastric tube to suction if the patient is vomiting. Consult. Gastroenterologist consult minus reason patient with possible cholecystitis. Complications. A. Acute pancreatitis. B. Ascending cholangitis. C. Gallbladder emptyema. D. Gallbladder gangrene emphysema-induced cholecystitis. Course. Spontaneous resolution in 60% of cases. Counseling. Patient counseling. Contraception counseling. Medication compliance. Safe sex counseling. Smoking cessation. No alcohol. No illegal drugs. Drive with seatbelt. Regular exercise. Preventive care. Asterisk. Cervical cancer screening, women 21 to 65 pap smear or 30 to 65 in combo with HPV testing. View recommendation details. A. Chlamydia screening minus women ages 24 and younger or women ages 25 and older at increased risk. View risk information. View recommendation details. Asterisk. Folic acid supplementation, all women planning or capable of pregnancy. View risk information. View recommendation details. Asterisk. HIV screening adolescents and adults. View recommendation details. Asterisk. High blood pressure screening, adults 18 and over. View recommendation details. A. Syphilis screening minus men and women at increased risk. View risk information. View recommendation details. Asterisk. Alcohol misuse screening and behavioral counseling interventions in primary care. Adults. View recommendation details. B. BRCA mutation testing for breast and ovarian cancer, women, increased risk. View risk information. View recommendation details. Asterisk.